All right, let's talk about something you are going to see almost every single day in the clinic: neck pain. It doesn't matter if you're in primary care or the ER, you need a solid game plan. And that's exactly what we're going to build today, step by step. So let's dive in.
So, why is this such a big deal? Well, get this. In any given year, a whopping 30% of adults in the US will have neck pain. That is a huge number. This isn't some rare diagnosis. It's a massive public health issue that you'll be managing constantly.
And it's not just that it's common, it can be really debilitating. In fact, it's the fourth leading cause of disability. It seriously impacts people's lives. So our number one job as clinicians is to be detectives. We have to sort through all these cases and figure out what simple muscle strain versus the rare but super serious stuff we absolutely cannot afford to miss.
Okay, so here's our game plan. We're going to start right where all good medicine starts, at the bedside. Then we'll get into the most critical part: how to spot those red flags. After that, we'll tackle that age-old question: to image or not to image? And finally, we'll wrap it all up with how to build a smart, effective treatment plan.
You know, everything really does start at the bedside. Before you even dream of ordering a lab or an MRI, you have to be an excellent detective. And your two best tools for that? A really detailed history and a focused physical exam. This is where the diagnosis truly begins.
Seriously, the patient story is your roadmap. You have to ask the right questions. How did this start? Was there a car accident? Has it been getting worse? Can they still go to work? And then the big ones. Does the pain shoot down their arm? Are they having fevers or losing weight without trying? Every single answer helps you build your case and tells you exactly what to look for in your exam.
Okay, so you've got the story. Now, the physical exam is where you start to zero in on the problem. You're feeling for tenderness, you're checking how well they can move, but most importantly, you're hunting for any signs of neurologic trouble. A complete sensory, motor, and reflex exam is totally non-negotiable. It's what helps you answer the next big question.
Your history and exam are basically trying to sort the patient into one of two big buckets. Is this straightforward musculoskeletal pain, like a simple neck strain? Or are we seeing signs of something neurologic, like a pinched nerve causing radiculopathy? The findings right here are your guide. Think of it this way: musculoskeletal pain usually stays put. Neurologic pain travels.
So let's get really specific about this term: cervical radiculopathy. This isn't just some vague radiating pain. No, it's a very specific syndrome. It's caused by a nerve root getting squeezed, and the symptoms, that pain, numbness, or weakness, follow a classic pattern down the arm. We call that a dermatome, and it can actually help you pinpoint exactly which nerve's in trouble.
Now for a real pro tip you can use at the bedside: the Sperling test. It's a move designed to try and recreate those radicular symptoms. But here's the clinical pearl, and this is so important. This test isn't very sensitive, meaning it's going to miss a lot of cases. So if it's negative, it doesn't really rule anything out. But it's super specific. So if it's positive, man, you can be pretty darn confident that you're dealing with cervical radiculopathy.
All right, so you've got a working diagnosis. But wait, before you go any further, you have to do a crucial safety check. You have to actively hunt for any red flags that might point to something much more serious, something that needs your immediate attention.
This is kind of your first pass filter. If a patient comes in with neck pain and also tells you they have a history of cancer, or they're losing weight like crazy, or they have a fever, or a history of IV drug use, your uh-oh meter should be pegging into the red. You have to be thinking about scary stuff like cancer or a deep infection.
Okay, everybody listen up. This slide right here, this is probably the most important one in this whole explainer. These are the findings that make you stop everything. For instance, if your patient has weakness in their legs or they're having trouble walking, you have to be thinking about spinal cord compression. And that, my friends, is a call neurosurgery right now kind of emergency. You need to burn this table into your brain. It's your ultimate safety net.
So all of this naturally leads us to one of the questions we all grapple with in the clinic. When do we actually need to order imaging for neck pain? Because the answer, as you're about to see, is definitely not all the time. So here it is. The million-dollar question. Does every single person who walks in complaining of a stiff neck need a fancy MRI scan? The evidence-based answer is a loud, clear no. Knowing when to pull that trigger and when not to is a key clinical skill.
So here's your cheat sheet, your rule book. If there are no red flags, you don't need to image acute neck pain. It's that simple. You'll start with plain x-rays if you're worried about a fracture, an infection, or cancer, or if the pain just isn't getting better after 6 to 8 weeks of trying other things. And you save the big gun, the MRI, for the really scariest stuff. When you suspect spinal cord compression, when neurologic symptoms are getting worse, or you have a really high suspicion for cancer or infection.
Okay, so we've ruled out the life-threatening stuff, and we've decided that most patients don't need an immediate scan. Now we get to the good part, focusing on what actually works to make people feel better. The best approach is always centered on the patient, starts conservatively, and uses a bunch of different strategies at once.
And here is some really great news you can share with your patients. The natural course of this is actually really good. For most people with that run-of-the-mill musculoskeletal neck pain, their symptoms are going to get a whole lot better or maybe even go away completely within about 2 to 3 months, just with simple conservative care.
Now, the cornerstone of treatment is not what's on your prescription pad. It's getting the patient actively involved. A mix of gentle range of motion exercises, maybe some formal physical therapy, and a good stretching program is absolutely key. Even simple things like an ice pack or a heating pad can make a huge difference. Medications are there to help, but they aren't the main event.
When we do reach for meds, we take it step by step. First up, we start simple with NSAIDs like ibuprofen, either as a pill or a topical cream. If there's a lot of muscle spasm going on, a short course of a muscle relaxant can be a lifesaver. And for that chronic, zinging nerve pain from radiculopathy, we might try a neuromodulator like gabapentin.
And I really want to land on this point because it is so important in today's world. This quote says it all. When it comes to neck pain, opioids are generally avoided. They just don't offer much benefit for this kind of pain, and they come with a huge potential for harm and addiction.
Okay, let's boil this all down. What do you absolutely have to remember for your next shift? 1. Most neck pain does not need imaging. 2. Save those scans for red flags or when conservative therapy fails. 3. Treatment should be active and use multiple approaches. And 4. The 2 things to almost always avoid are cervical collars, which can actually slow recovery, and opioids.
So I'll leave you with this question. You now have a solid framework to approach neck pain safely and effectively. After going through all this, which red flag finding is the one that's now burned into your brain, the one you'll be hyper-vigilant about to make sure you never, ever miss it?